Good afternoon, Honorable Dr. M.L. Swarankarji, Dr. Vikas Swarankarji, Dr. Sudhir Sachdev, Dr. Hemant Malhotra, Dr. Swati Garg, and Dr. Raj Govind Sharma. I am overwhelmed by the warmth and hospitality that has been shown to me by the Mahatma Gandhi University of Health Sciences and Technology. And I'm deeply grateful for the honor and privilege that you have bestowed on me, and I accept it with great humility on behalf of my institution, the Advanced Center for Treatment, Research and Education in Cancer. I will begin with my oration. On your screen now on the left is a picture of Tata Memorial Hospital, and on the right is a picture of the Advanced Center for Treatment, Research and Education in Cancer, which is a 63-acre campus in Navi Mumbai, about 40 kilometers from the main hospital in Parel in Mumbai. My profound gratitude once again to Dr. M.L. Swarankarji, Dr. Vikas Chandra Swarankarji, Dr. Sudhir Sachdev, Dr. Hemant Malhotra, and all your colleagues for the privilege and honor of the Srimati Gomti Devi Swarankar Oration 2023. And once again, it is one of the great privileges of my life to deliver this oration today. Clinical medicine and clinical research, comrades in arms. These are two themes that have been close to my heart throughout my career, and I will trace my journey of whatever little I have been able to do in the next about 35 minutes. I am cognizant of the fact that the audience is not only oncologists. A large proportion of the audience is non-oncology, so I will try to keep it as non-specialist as possible. I am a creation of my circumstances and opportunities. There are many others who have been far more talented than I am, but have been less fortunate because of inadequate opportunities. Every day of my life, I am grateful to Providence for the privilege and opportunities that I have received throughout my life. To be a physician is my highest achievement. In my introduction, a lot of things were said about me. I am not nearly as eminent as I was made out to be, including the fact that I hold some administrative posts, such as the director of one of the biggest centers in India. But I have to say that to be a physician is my highest achievement, and I became a doctor because I liked to become a doctor and help to treat patients. I have felt blessed and have enjoyed every day of this journey. It is a never-ending journey. Every day is a new struggle, but a struggle that is very rewarding. Patients come to me for succor and solace before they want treatment. I used to be the editor-in-chief of this journal called the Indian Journal of Medical and Pediatric Oncology, so I'm the former editor-in-chief. And one of the privileges of being an editor is that you can inflict your editorials on the readers, whether they like it or not. So this is one such editorial that I wrote, Cat on a Hot Tin Roof. And I will quote myself. There is a movie called Cat on a Hot Tin Roof. Some of you may have seen it. There is a Big Daddy character there. The Big Daddy character with terminal cancer refuses to accept morphine from his son. You get the pain and you know you are alive. The quest to live is one of the most potent emotions in humans and is sometimes difficult to endure when projected onto oneself from another. My oncology colleagues in the audience will understand this when we see sometimes terminally sick cancer patients in our outpatients and in other departments. The quest to live is the most potent human emotion and is the reason why we became doctors. I try to strive towards clinical excellence, not for myself, not because I want accolades. Maybe accolades will come along the way, but for my patients. It is our duty as doctors to be excellent in what we do, because that will be of great help to our patients and help them recover faster, sooner, and better. I have learned that the art of listening is the most impactful diagnostic technique. And this is yet another editorial that I wrote for the journal. To listen is to be. And this is when I was doing oncology as a faculty member at Tata Memorial Center. I recently listened to a patient describe increasing levels of breathlessness in a very precise manner. He could now ascend only 3 flights of office stairs before feeling breathless, whereas he could do 7 floors earlier without breaking a sweat. This was a Saturday, and I have enough and more time on my hands. He happened to be the brother of one of my colleagues in the faculty of TMH. And I, after careful listening and auscultation, diagnosed this 43-year-old gentleman to have valvular rheumatic heart disease that had remained asymptomatic and undetected in the 4 decades of his existence. I sometimes ask myself why, and the answers are often very impactful for my patients. Why did this otherwise normal woman develop acute renal failure with a creatinine of 5.4 milligrams per deciliter 6 days after receiving a routine chemotherapy for breast cancer called CEF, which has cyclophosphamide, epirubicin, and 5-fluorouracil? The residents told me that she vomited a lot and perhaps she had pre-renal azotemia. She became dehydrated, and therefore she developed severe acute renal failure. I asked myself, how many times have I seen patients with this kind of a presentation develop such severe renal insufficiency only as a result of vomiting? I went to the patient, I took a careful history, I listened to them, and I found out that this patient was taking an alternative medication starting about 5 days before the first cycle of chemotherapy in order to reduce the side effects of our treatment. And we reported this in a journal. You can see that the alternative medication has 10 heavy metals that are listed there, and the amounts are an order of magnitude higher than the recommended dietary allowance per day. Why did this woman, referred to me for metastatic breast cancer with multiple lung metastases, develop a recurrence just 6 months after completing a full 1 year of a good treatment? After all, she had a small node-negative breast cancer and she ought not to have relapsed. I asked myself this as I examined her, and while I was examining her, I found that there was a port in situ that hadn't been there for the past 2 years. Something did not add up, and we diagnosed this patient to have a very rare syndrome or a very rare infection, nocardial endocarditis in her native aortic valve that had caused infective endocarditis with lung infiltration and lung nodules, which had been masquerading as lung metastasis. I love quantitative and probabilistic reasoning. I have realized that probabilistic thinking and reasoning does not come naturally to most of us. I work hard to try and grasp the probabilistic foundations of our reasoning. And this is yet another editorial that I wrote. I had the privilege of expressing myself when I was the editor-in-chief. And again, I will quote myself. I believe that human affect is deeply antithetical to uncertainty and probabilities. Our species is more comfortable with certainties, including discomforting ones like death. But we are not alone in our discomfort with probabilistic reasoning. Albert Einstein famously lamented that God cannot play dice. As it turns out, God does play dice. Because of my love for statistical reasoning, for probabilistic thinking, I have been fortunate to collaborate with colleagues outside my area of expertise. So it was said during my introduction that I am an expert in lymphoma, breast, and gynecological cancers. I used to treat lymphomas many years ago, but I gave it up. Now I only treat patients with breast and gynecological cancers and conduct research related to only these two and related themes. So this is a report of a clinical trial that was published in the New England Journal of Medicine, a single institution paper in NEJM about 7 years ago by my colleague Dr. Anil De Cruz. And the reason why I'm there in this paper is because I contributed to the statistical design and analysis of this paper. And this was one of the path-breaking results from our country that was presented by Dr. De Cruz at the plenary session of ASCO, showed that performing elective neck dissection in patients with clinically node-negative necks, patients who have oral cancer, it improves both the overall and the disease-free survival, as you can see on this slide. I believe that much of the intuition in medicine is the skill of integrating prior probabilities with the current information about the person in front of us. This is formally known as the Bayes theorem, and this is implicit in the cognitive processes of all great clinicians. So let me share with you some of my thoughts as a physician. The practice of medical oncology tests its practitioners like almost no other specialty, with due apologies to all others. We have a large number of drugs which are growing in number, a whole lot of side effects which can affect almost any organ system and tissue of the body. We have a number of metabolic disorders, and therefore, even while being focused on oncology and the cancer, we have to be complete physicians if we have to do justice to our patients. The scans are useful. So we have advanced imaging techniques, PET scans, CT scans, MRI scans, PET MRI scans, a number of nuclear medicine scans, but we treat the patient and not the scan. So there is one system of gauging response to treatment that is called RECIST. It is used by oncologists because it is a quantitative way of figuring out by how much the tumor has reduced. But I often, not often, but at least sometimes I feel and I think and I find out that RECIST may not necessarily track with a patient's clinical and human trajectory. So I have learned not to overscan my patients. So let me share with you some of the research work that we have done as part of the gynecological and breast cancer teams at Tata Memorial Center. So this is a clinical trial that I was the principal investigator of, and I had the good fortune of presenting in the plenary session of the European Society of Medical Oncology conference in Madrid in 2017. Neoadjuvant chemotherapy followed by surgery versus concomitant cisplatin and radiation therapy in patients with stage 1B, 2A, or 2B squamous carcinoma of the cervix. This was subsequently published in one of the top journals of oncology, the Journal of Clinical Oncology. So, up until the results of our trial were presented and published, there were two treatments for locally advanced cervix cancer. One, which was practiced primarily in North America and some parts of Asia, was giving radiotherapy simultaneously with once-a-week chemotherapy using a drug called cisplatin. This is called concurrent chemoradiation. The other treatment was to give full-scale chemotherapy for up to 3 to 4 cycles and then try to surgically operate on the patient. This is called neoadjuvant chemotherapy followed by surgery. And this was primarily practiced in many parts of Europe, Italy, Spain, many others, East Asia, and also in parts of Latin America. There had been no comparison between these two ways of treating cervix cancer, but this comparison was extremely important because if you operate on a patient who doesn't deserve to be operated, you might be harming that patient. If you do not operate on a patient who actually might benefit from that surgery, you are again doing a disservice to that patient. So we actually designed and planned this trial in 2003. These were patients of squamous carcinoma of the cervix in the stages that are listed on the left box on the slide. After stratification by stage, they were randomized 1:1 to receive either neoadjuvant chemotherapy followed by surgery or CTRT, which is concurrent radiation and chemotherapy. We randomized 635 patients over a 12-year period from 2003 to 2015, and after a median follow-up of close to 5 years, we reported the results, and our results showed that concurrent chemoradiation, giving radiotherapy with once-a-week chemotherapy, is superior to doing chemotherapy followed by surgery in these patients, and the outcome is measurably and statistically significantly better with the use of concurrent chemoradiation. The result of our trial changed the practice of treating cervix cancer in those parts of the world, including in many parts of India, where neoadjuvant chemotherapy and surgery had been the default standard up until then. This is one of the newsletters that ESMO brings out. Our study was highlighted as one of the highlights of that conference. It was also considered to be one of the best papers that have been published, and one of the most highly cited papers that have been published in JCO in the past few years. So the implications of our work have been tremendous. All the major guidelines of the world, including up to date that some of you may be familiar with, have incorporated the results of our trial and have now accepted that radiation plus simultaneous chemotherapy is the default standard way of treating these patients. And we have suggested, including to policymakers, that there is good evidence to not practice neoadjuvant chemotherapy and surgery, even in those areas of the world where radiotherapy infrastructure is lacking. And this study forms the basis of those referral guidelines. Interestingly, there was a European trial that also started in 2003, and a near identical trial, but they presented the results 2 years after us at ASCO, which is the American meeting, and they confirmed our results. This is another study that our gynecology group performed simultaneously with the neoadjuvant study, but this was in an even more advanced group of patients with stage 3B cervix cancer. Now, in stage 3B cervix cancer, there had been no consensus whether giving simultaneous chemotherapy with radiotherapy is a useful technique or not. So we ran this trial, added chemotherapy simultaneously with radiotherapy, or gave only radiotherapy to the two arms of the study, and there were more than 900 or about 900 patients in this trial, and you can see that the outcome is better with giving cisplatin once a week in this group of patients. This was published in the JAMA Oncology. So over this 12 to 13-year period, our gynecology group performed 2 studies. One was in patients with stage 1B, 2A, and 2B carcinoma of the cervix, and the other one was in stage 3B. In both of them, we showed that concurrent chemoradiation was better than neoadjuvant chemotherapy and surgery and radiotherapy alone, respectively. We have recently had the opportunity to document the contribution of our center to cervical cancer care in India, including recapitulating a history of gynecologic oncology in the article that is at the bottom of this slide. So we have contributed to the jigsaw of cervical cancer and improved the care of patients. Our contributions will perhaps remain a small footnote 30 or 50 years from now, but we would have contributed at least a few steps to a journey of 1,000 miles. Let me come to breast cancer. Treatments may be effective, but they are useless if patients cannot access them. Trastuzumab is a HER2-targeted therapy that was considered a revolutionary treatment in 2006 when the first results of this drug in the adjuvant setting came out. This is an editorial by Dr. Hortobagi in the New England Journal of Medicine, where he called this treatment not evolutionary but revolutionary. So we audited a single-year cohort of our patients of 2008. There were 441 patients who were eligible to receive this drug. but only 38, which is about 8.5%, ended up receiving this drug. The reason? It was prohibitively expensive for patients to access this drug. So we tried to improve access to this drug. We forged social partnerships and philanthropic support for patients. We consistently advocated for use of shorter durations of adjuvant treatment. And of course, more recently, there is now the availability of lower cost biosimilars that has improved the access to this drug remarkably, about 15 years from the time that we first started this journey. We again audited our cohort of patients of 2016, and you can see that the access has improved from 8.5% to about 60% in 2016, and now at Tata Memorial Center, all our patients are able to access this drug. We conducted a study to measure the cost effectiveness of trastuzumab with colleagues from PGI Chandigarh, and we found that the use of 9 to 12 weeks of trastuzumab is cost effective given current India GDP per capita and the ability of our population and our government to pay for this drug. But 1 year of trastuzumab, which is the standard way of giving it, is not cost effective. So, you have heard me saying that we have advocated that you can give 3 months of this drug instead of 1 year. But some of you may stand up and ask me, is there evidence to say that we can give only 3 months and get away with it? Is it as good as giving 1 year of this drug? So there have been 6 randomized trials conducted mostly in Europe that have tested the use of shorter durations of trastuzumab compared with 1 year. But none of them, barring one, the British trial, could conclude non-inferiority of shorter duration. So what did we do? We conducted an individual patient data meta-analysis. It is the most difficult meta-analysis to conduct. And we pioneered with my statistical colleague, we pioneered a technique to extract individual patient survival times from published survival curves and literally conduct an individual patient data meta-analysis from these trials. So this is just to show the exquisite accuracy with which we could extract the individual patient survival times and reconstruct the survival curves. What did our meta-analysis show? So you can see in the denominator, both on the left and on the right. On the left is disease-free survival, on the right is overall survival. These are close to 11,000 patients, half of them receiving 1 year of trastuzumab, the other half receiving less than 1 year of trastuzumab. And you can see that both the disease-free and the overall survival are very close to each other. So we concluded that about 3 to 6 months of trastuzumab are as good as giving it for 1 year. Again, we have contributed to the evolution of a cost-effective, evidence-based treatment option with wide applicability, not only in India, but in many other parts of the world that are home to at least 60% of the world's population. I also have the good fortune of being the General Secretary of an NGO called the Women's Cancer Initiative. You can see in that picture, I'm in the middle. To my right is the current director of Tata Memorial Center, Dr. Rajendra Badwe. To my left is Mrs. Devika Bhojwani, who's herself a breast cancer survivor and who took the initiative to start this NGO. And I have been associated with it for the past more than 20 years. So we conduct programs, we try to raise funds for helping women patients with breast and gynecological cancers through the activities of this NGO. Yet another clinical trial result that has immediate and widespread applications not only in India but worldwide. So this is a randomized controlled trial that again I had the good fortune of presenting on behalf of the Breast Cancer Working Group at the San Antonio Breast Cancer Symposium about 4 months ago in December of 2022. This is addition of platinum to sequential taxane anthracycline neoadjuvant chemotherapy in patients with triple-negative breast cancer. So some of you know that the most important drugs for treating triple-negative breast cancer are anthracyclines, doxorubicin or epirubicin, along with taxanes, paclitaxel or docetaxel. For a long time, there has been a question of whether adding platinum to these two groups of drugs is useful or not. And this is an extremely important question because platinum is not a very expensive drug. If it does improve the outcome, then it should be given to all patients or at least subgroups of patients with triple negative breast cancer. There have been 3 randomized trials prior to our study. All of them have been phase 2 trials. There are much smaller trials than us, and their results were iffy. They were equivocal. Some said yes, some said no. And there was no good answer to this question. So I had the privilege of making a podium presentation at the San Antonio Breast Cancer Symposium about 4 months ago. And in its very essence, we randomized patients to receive platinum or not receive platinum along with the standard chemotherapy being given in both the arms. And the patients then underwent surgery and radiotherapy as per standard procedure. You can see that this trial cooked for almost 10 years, April 2010 to January 2020. We randomized 720 patients, and we had a median follow-up of 67 months in June 15, 2022, at which time, by which cutoff we reported our results. The reason I'm showing you this slide is that to conduct impactful and practice-changing trials cannot be done in 1 year or in 6 months, because cancer patients' outcomes takes years and years to track and follow up. You have to build a whole cohort of patients. You have to follow up that cohort for several years, and only then are we able to definitively answer the question. So the results of our study showed that in the whole study population, there was a 6.6% improvement in disease-free survival with the addition of carboplatin. But we also found out that the benefit was entirely limited to women younger than 50 years of age, and in older women, actually, there was no benefit. The same results with overall survival. You can see that there is a 7.6% improvement in overall survival, and this is the highest bar that an oncology trial can achieve, improvement in overall survival, and this was statistically significant. But again, the benefit was entirely confined to women who were younger than or equal to younger women and not to older women. The toxicity of carboplatin, all oncologists know about carboplatin. It was not such a toxic drug. It was well tolerated. We concluded that addition of carboplatin to taxane anthracycline chemotherapy should be the standard treatment in patients with triple negative breast cancer who are younger than or equal to 50 years of age or who are premenopausal. So the implications of this trial, now almost all the groups in the world wish to collaborate with us, the Germans, the Americans, the British. They want the blocks of this study to conduct translational studies to be able to find out why age is interacting with the benefit of carboplatin. But in the meantime, carboplatin can now be considered the standard treatment in addition to anthracyclines and taxanes for younger women with triple negative breast cancer who are being treated with neoadjuvant chemotherapy. My colleagues, I have had the good fortune of working with a number of gifted colleagues in my institution. For a long time, there has been a question that when a breast cancer patient presents with stage 4 disease, should you operate and remove the primary tumor or not? So Dr. Badwe, who's my colleague and the current director of Tata Memorial Center, planned and ran this study. I have the good fortune of being the last and senior author on this paper in Lancet Oncology. And we showed that performing surgery in patients with metastatic breast cancer is not a useful idea. It's not a good idea. And this was contrary to the evidence from retrospective studies which was being used by clinicians all over the world to perform these surgeries. So this is one more piece of evidence that has changed practice in all parts of the world. So let me come to some studies where I have been involved in understanding the biological makeup and evolution of tumors. So Nilesh is my PhD student. He's registered as a PhD in Health Sciences in Tata Memorial Center. We conducted a study, and this is a paper that is about to be published, the life history of germline BRCA1 mutated and BRCA wild-type triple-negative breast cancer. So our hypothesis was, and it is very important to also conduct hypothesis-driven research apart from descriptive research, we hypothesized that invasive cancer evolves clonally during its lifespan under Darwinian evolutionary pressures. So some of you have read Darwin. Every organism, every cell is subjected to selection pressures, and therefore organisms and cells evolve during their lifetimes, and each successive relapse is characterized by unique genetic and epigenetic footprint. Characterization of a patient's tumor's evolution over time will lead to important understanding about its makeup and also about treatment. So this is the study that we did. We performed longitudinal tumor sampling from individual patients from their primary tumor at the time of diagnosis and at the time of each successive relapse. So if a patient relapsed 4 times, we sampled from wherever that tumor was 4 times or 5 times through the life history of that patient. And this is an exceptionally difficult study to conduct because you have to longitudinally sample patients. And at each of those time points, we subjected the blood and the DNA of that patient to whole exome sequencing at 200x, SNP arrays for copy number variation, deep transcriptome sequencing, and also an ultra high depth DNA sequencing for only a targeted panel of about 1000 hotspots at 20,000x. So this is a difficult study to conduct. It is one of the very few studies of its kind in the world. And what we found was that there is a mother clone in each tumor. There is one mother clone that stays throughout the life history of that tumor. But as you can see, at each successive relapse, it keeps off giving daughter clones. So the one mother clone, the blue color, for example, stays throughout, but then it keeps off giving various daughter clones at time that determine the phenotypic property and perhaps the resistance or sensitivity to various treatments during its lifespan. So the copy number variations or alterations increase over time. We also subjected the blood of these patients to circulating tumor DNA analysis, and we found that apart from biopsying the solid tumor, you can capture the entire genetic makeup of that tumor from the liquid biopsy. This was also done at ultra high depth. And we concluded that in germline BRCA1 so 2 of these 3 patients had germline BRCA1 mutation. So in both BRCA1 mutated and BRCA wild type patients, TNBCs show a branching evolutionary mutational pattern with a single founding clone. They are polyclonal throughout their disease course and have widespread copy number aberrations. This pattern could be therapeutically exploited. So and I'm just showing you an example of each kind of a study that I have been involved in. There are a few others that I am doing with my PhD students and with my lab members, but I will not show all of them. This is neither the occasion nor the time to do it. These kind of basic science and translational studies have broadened my horizons and allowed me to peek into the minds of gifted scientists. The two-way interaction keeps my mind and senses alive and ticking. My final thoughts. This is a gentleman by the name of Dobzhansky, and he said more than 50 years ago that nothing in biology makes sense except in the light of evolution. Over a period of time, I have felt the force of this statement and have begun to understand its meaning and implication. Where were we in the past, and will an understanding of our past help us to gaze at our trajectory as we go into the future? So this is a cartoon that I drew for myself during one of my previous lectures. On the y-axis is progress, whichever way you define it, and on the x-axis is time. Progress can be linear over time, it can be exponential, or it can begin to plateau. What will happen in the future, of course, intuitively depends on which trajectory we are following, but very importantly, and this is often not appreciated, it is very important to gain some understanding of where we are at present on the arrow of time. Are we on the linear portion of that curve, or are we beginning to plateau? Are we going exponential? So this is just some philosophical thoughts. Some of you may think about it in the days and years to come. I have been fascinated by the topic of artificial intelligence. I have no expertise, but I've been fascinated by it. All of us have our fascinations. So the game of chess is the longest studied domain in the history of AI. The strongest programs, and now you know that world champion humans are routinely beaten by computer programs at playing chess. Gary Kasparov was beaten and then he retired. All the current, the best players of human players of chess cannot match the computer programs. But all these computer programs, until very recently, are the ones where you have fed enormous amount of prior data. They analyze all the moves and then they make their next move. So this is what has happened until now. Now the question is, can you teach a computer to learn a task, for example, playing chess, from only the first principles, only telling it the rules of the game? If you tell a computer program that a bishop can move this way, a queen can only move in these directions, as a child would learn. As a child would learn how to walk, can you teach a computer program to do this? And then allow it to learn from its own experience. So it plays, it learns, the child walks, it learns, and then it tries harder, it tries better, and then it eventually learns how to walk and run. So this is a paper that was published in Nature about 4 years ago. This is one of the best papers that I've read. In this paper, starting from random play and given no domain knowledge except the rules of the game, this program called AlphaZero convincingly defeated a world champion program in the games of chess, shogi, and go. So these are all board games. The computer program was only taught the rules of the game and no prior data, and it beat both humans and the existing computer programs at all these three exceptionally difficult games. So I think artificial intelligence is here to stay, not only in the routine mundane tasks that we think it will do, but maybe in many other things. So at Tata Memorial Center, with my colleague Sapnil Rane, I am the principal investigator of an imaging biobank for cancer that has been funded by the Department of Biotechnology. And what we are doing with our collaborators from AIIMS, PGI, and Rajiv Gandhi Hospital in Delhi is to bank images. So there are two kinds of images that we bank for the chosen tumors. One is the pathology slide, the whole pathology, the whole slide scanned in a defined manner, an H&E section, immunohistochemical sections, and also the corresponding radiology images of the same patients at baseline and longitudinally over time. And we have committed to the Department of Biotechnology that once this bank is created, and it is about to be created and we are about to launch it, the images and the linked clinical data of these patients, whether they recurred, whether they died, whether they lived, will be available to all researchers from India. And so this is something that will immediately increase the data for artificial intelligence researchers throughout India to work with a cancer data set. So these are some of the books that have deeply influenced me. There are many others. I used to be an avid reader. I no longer have the time. War and Peace of Human Bondage, and a wonderful book called Yugant. It is a commentary on each character of Mahabharata by a Marathi literature called Iravati Karve. And if some of you have the time, it's a very thin book. It is the most wonderful book that I have ever read. I'm grateful to my MBBS and MD teachers at AIIMS. Some of them seemed harsh to me when I was training, but because of them, I learned exactitude and clinical excellence. And for this, I will remain eternally grateful to each of them. I'm grateful to my medical oncology mentors at AIIMS. They inculcated in me a love for this subject, and their dedication to their work has been a lasting impression for me. I'm indebted to my medical oncology colleagues and students at Tata Memorial Center, both past and present. They have been kind and supportive, and I'm here today because of them. I'm grateful to the leaders of Tata Memorial Center. They have reposed faith in me despite my numerous shortcomings. I'm proud of my research team. They have been comrades in numerous scientific expeditions. I'm grateful for the lasting friendships that I made during my training. This is the class of 86 MBBS at AIIMS. I fondly remember my late parents, and I'm fortunate to have a loving family. Thank you very much for your attention.